My name is Shannon Anderson, and I am living with metastatic breast cancer. And I'll be facilitating this session on liver and visceral metastasis. I get tongue twisted on that. We'll have a presentation followed by questions and answers as time allows. And you can use, there's cards inside your folder. Feel free to write your questions down and we'll collect them at the end. And they just would like you to be mindful of your questions, that it is broad enough that would benefit everybody here, so it's not super personal, but more maybe everybody could benefit from your questions. At the end of the session, you'll have time to maybe talk to some people and meet some people and share your experiences with everybody else. And after the session, we'll have a short break, and then we'll have dessert, and in the main room. I'll share a little bit about myself. My name is, I already told you my name, Shannon. I was diagnosed almost 3 years ago, next month, with breast cancer that had spread to my liver, all in the same week, breast cancer and liver. And it had covered 2/3 of my liver, kind of like a leopard, because they're lesions, as most of us know. And I have actually had really great results on Lupron, Ibrance, and letrozole. I'm down to one teeny tiny little spot in my liver, and that is all. So, my friends all tease me that I'm Julie. Does anybody know who Julie is? In the Ibrance commercial? We hate Julie, right? Yeah. I have some small side effects. My joints and my body thinks it's 80, my head still thinks it's 30. And I'm not 30. I actually just became a grandmother for the 5th time this week. So, I have a lot of living to do, and I'm really hopeful with these medications and everything we have to learn here. I don't know about you guys, but I've learned so much. And I actually got my degree from University of Google. So learning real stuff is amazing. I just am soaking it all in. I hope you guys are too. Now it is my honor to present Dr. Louise Vandermolen. He's the oncologist at Keck Medicine of USC. Dr. Vandermolen is a practicing hematologist, oncologist, and internal medicine specialist going on 39 years. He currently practices at Orange Coast Oncology and Hematology Medical Associates and is affiliated with Keck Hospital of USC as a clinical professor of medicine and Hoag Family Cancer Center. Whew. Please help me in welcoming the doctor.
39 years, I'm not sure about that. What I do know is when I graduated from medical school, I was very young. I grew a beard to look older, and I wore that beard for about 20 years and then cut it off because I needed to look younger. So, congratulations on your progress and
Thank you.
status. So the subject today, metastatic breast cancer, which would of course be stage 4. That stage 4 that everybody fearful of and doesn't want to hear, but it is stage 4. And then we're going to focus a little bit, sort of drill down on metastatic disease involving the liver. So there's about 200,000 women every year diagnosed with breast cancer in the United States. And of those 200,000 women, about 20% will have stage 4 metastatic disease at the time of diagnosis. So when they are first discovered to have breast cancer, they have cancer in the bone or the brain or the liver, but someplace outside of the breast. So 20% of 200,000 is a big number. And of those 20%, at least half will have liver metastasis. So right at the time of diagnosis. In addition to that, women who have stage 1 or 2 breast cancer during their journey, during their course of treatment, during their journey with breast cancer, they'll develop liver metastasis. So 20 to 25% of stage 1 and 2s will ultimately develop liver metastasis. So you can see from those numbers, it's actually a formidable number of women who will face this and fight this and battle this. And fortunately today, successes are much higher than they were even 10 years ago. Push a button. I just push any button, see what happens. Let's try that.
aren't organs ejected.
Okay. Okay, so what are the goals when you see this, when someone presents with this, when you get diagnosed with this, you have to kind of define where you are, define where you're going. What's the goal? What direction are we going and what are we trying to achieve? Well, the first and foremost thing is to improve survival. So you want to take a treatment, you want the cancer to get better, you want the cancer to get smaller, and you want to live longer, and you want quality of life. So you want to live longer and you want to live a good life. And what those goals are and how they're dependent, what the success rates are, will be determined by the biology of the tumor. If it's biology meaning, does it have the estrogen receptor, does it not? Does it have the progesterone receptor? Does it have a gene called HER2/neu? Is it a fast-growing cancer? Is it elevated what's called Ki-67? These are all parameters that tell you something about outlook and prognosis and the chances of success with treatment. But there's also clinical factors that will tell you someone has an extensive area of cancer in the liver. That's a more formidable problem than someone that has one or two little spots in the liver. If somebody has a lot of areas in the liver and other areas of the body, the bone, the brain, that's a more serious problem, a more difficult problem to treat. So those are factors that you have to think about when defining what you're going to do. You have to define what the problem is to really tailor what the best treatment is for this individual person. There's a subset of patients that have what's called oligometastatic disease. And oligo means little. So these are patients that have a small amount of cancer, and specifically a small amount of cancer within the liver. So a woman that has one or two or maybe three deposits of cancer in the liver and nothing anywhere else, no cancer in the bone or lungs, they can be treated with intensified local regional therapies with different goals. So in those patients, they can be treated not only directed toward prolonging life and survival, but actually cured. Those women can be cured of their cancer, go away and never come back again. And sometimes you'll see someone who doesn't have oligometastatic disease, but they're close. So you can give them treatment to sort of shrink down the cancer, make it smaller, make less cancer, and then convert them into somebody who does have oligometastatic disease, and then move from there into a curative mode. The cornerstone of therapy, the sort of the blueprint, the backbone of therapy is systemic treatment. So systemic is whole body treatment. So it's never a problem that's just localized to the liver. Remember, the way it got there was through the bloodstream. So it started at the breast, got in the bloodstream, that's how it got to the liver. So the treatment has to go in the bloodstream, has to go through the same pathway that it got there. And it can get into the bloodstream by pills that you take that get in your gut, that get absorbed in your blood, or it can be chemotherapy that's injected into your bloodstream, or biologic therapy. So endocrine therapies are therapies that work through the estrogen receptor pathway. There are pills that block estrogens as they circulate in your blood, like tamoxifen. There are pills that block the production of estrogen from your adrenal glands, aromatase inhibitors like Femura, the drug that she mentioned a moment ago. And then there are also drugs that block the receptor. So estrogen receptors are on the surface of cancer cells, but if you take that receptor away, then even if there are estrogens circulating in blood, there's no target for those estrogens to stimulate, and so that blocks the mechanism. The point is that there are different pathways, and you may use one pathway or may use another pathway, but you can try a third or fourth pathway that will be successful. So there's more than one way to sort of challenge or target the estrogen receptor. In addition to that, there are new drugs that we're going to talk about in a minute called CDK inhibitors that enhance the effectiveness of drugs that target the estrogen receptor, make these drugs more effective, and also help prevent resistance. So we'll talk about those in a minute. Chemotherapy, we all know what that is. Those are drugs that kill cancer cells. It's injected in the bloodstream, blood goes everywhere. So it's going to go to the liver, but it's going anywhere else in the body as well. And finally, biologic therapies. The initial biologic therapies that we used for breast cancer were antibodies targeting certain proteins on the surface of cells or certain genes like Herceptin or Perjeta. Those are antibodies that target the HER2 oncogene. But more recently, we have biologic therapies that work through the immune system. They target a protein on the surface cell called PD-1. PD-1 stands for programmed death. And these are immune therapies that help the immune system to better identify the cancer cell and help your own immune system to kill and eradicate the cancer cell. Again, those are drugs that are injected, they go in the blood goes everywhere, so they'll be effective in the liver as well as anywhere else in the body where there might be cancer existing. Okay, so when faced with this problem, to define what the best treatment is, to define what direction to go in, you have to get some sense of what the outlook is and some sense of what the prognosis is. You have to really tailor the treatment to the individual person. No two people get treated the same. It's individualized. And so there are factors that we look at to try to define what the best treatment is. Some of them are biologic factors that we'll talk about, and then there are other things that are clinical factors. So biologic factors that help talk about prognosis or outlook are, first of all, the estrogen receptor. Patients that have tumors that are estrogen receptor positive and progesterone receptor positive have both do better than patients that are estrogen receptor positive but progesterone receptor negative. So if you have both, the chance of responding to treatment, the survival, the durability of the treatment is going to be better than if you're ER positive and PR negative. And then if you're ER positive and PR negative, you'll do better than someone that's negative for both. So that's close to the triple negative, right? ER negative, PR negative, and the other one would be HER2. So if you're negative for both ER and PR, it's a more aggressive cancer, more difficult to treat. But if you're ER/PR positive, first of all, you have more options to treat it. You can treat through the estrogen pathways. And secondly, the outlook is better, the prognosis is better. HER2 is an oncogene. About 25% of patients will have this gene in their tumor cells. It's not something they were born with. It's not genetic. It's not hereditary. The tumor cells are acquired by mutation. But it programs the cells to behave badly. It programs the cells to divide and spread. So from a prognostic standpoint, if the tumor has HER2, it's a more aggressive cancer. But it's sort of a double-edged sword because on the other hand, we have drugs now that target that gene, which actually makes the outlook even better because they can be treated with Herceptin-based therapies, Perjeta-based therapies, oral agents like lapatinib, neritinib. So these are all drugs that target this. So even though when diagnosed and the tumor has HER2, even though that sort of portends a bad outlook, with appropriate therapy, it actually becomes a good thing. And then lastly, tumor burden. The more cancer in the liver, the more cancer in the body, the harder it is to treat, the more difficult it is to treat, and often the more short-lived the benefit's going to be. Now, I want to make one point about biopsy. First of all, when someone develops cancer, breast cancer, and you see a spot in the liver, you should be very careful not to assume it's cancer. It might not be. It could be fat in the liver. It could be something called focal nodular hyperplasia, which is benign. It could be an infection. It could be something altogether different, a different cancer. So it's important at the time of diagnosis, not down the road later, but it's important initially to do a biopsy to prove that it is in fact what you think it is, because it might not be. I can't tell you how many times people have assumed that they had cancer and then we biopsied and it wasn't. It was something totally different. So that's the first reason to do a biopsy. We've already done a biopsy of the breast, but now you have a spot in the liver, and what I'm saying is often you should biopsy that as well to be sure it is what you think it is. But secondly, there's two other phenomena that can occur that would necessitate biopsy. Now we're talking about biopsy of the liver, and one is a process called conversion, and the other one's called discordance. So conversion is what happens when somebody has breast cancer, and then 2 or 3 years later they get a scan and you see a spot in the liver, and you assume it's breast cancer. And maybe their original cancer in the breast was estrogen and progesterone receptor positive, and maybe it was HER2 positive. But then if you take a biopsy of it 3 years later, it changed. It converted. It may go from estrogen receptor positive to estrogen receptor negative, or it may go from HER2 positive to HER2 negative. Very important to know, because if you have some recurrence of cancer, it's in the liver, and you treat it assuming that it has the same characteristics as the original cancer, you could be taking the wrong treatment. In other words, if it's converted from an estrogen receptor positive cancer to an estrogen receptor negative cancer, hormone therapies aren't going to work, although you might have thought they would based on the original pathology. So you can see conversions from estrogen receptor positive to negative in about 15% of cases, but the estrogen receptor can convert the other way. It can go from negative to positive in about 15% of cases. So you can see a patient who you think hormone therapies won't work, re-biopsy and find out that they will. And as far as HER2 goes, about 10% of the time it can convert from HER2 positive to HER2 negative. But the chance of it going the other direction only happens about 1% of the time that it'll be HER2 negative and then become HER2 positive. So that's the process, the phenomenon of conversion. So that's in someone who develops cancer at a later date. But the other phenomenon is called discordance. And that's where a woman presents, she has breast cancer, there's a lump in the breast, they take a biopsy, and it shows certain characteristics. It's ER/PR positive, HER2 positive, let's say as an example. But then we do a scan and we find a spot in the liver, and we take a biopsy of that, and it's different. It's the same cancer. It's a ductal cancer, negative breast. It's definitely the same cancer. But the cancer cells that are spreading are behaving biologically different from the cancer cells that stay in the breast. Cancer cells that got in the bloodstream and spread are ER negative or PR negative. So, and that's what you need to treat. The cancer in the breast can be operated on, it can be removed, but what's life-threatening is what's in the liver. So you have to tailor the treatment to the cancer in the liver, not the cancer in the breast. That happens about 10% of the time when women are diagnosed. So when there's a first diagnosis, when you first see it, it's important to do a biopsy, confirm that it is in fact what you think it is. Be sure that there's no conversion change in its characteristics or phenotypes, because if there is a change, that could definitely have implications on what the best treatment is. Again, talking about outlook, prognosis, there are also clinical factors that are important in trying to define the problem and define what goals are. First of all, the time from initial treatment to the time of recurrence. So if you have breast cancer and you take treatment for it, finish your chemotherapy, let's say in December, but by July the next year, the cancer reappears in your liver, that's a serious problem, because think about what happened. There were microscopic cancer cells there in December when you finished chemotherapy, and they've grown to the point of being detectable 6 months later. So first of all, they have to have resistance to the previous treatment. They survived it. And secondly, they grew pretty rapidly to be detectable. So that cancer is aggressive, it's growing quickly and needs to be treated aggressively. Whereas if it's a long time from when you finish treatment to the time of reoccurrence, outlook is much better. That's a very indolent, slow cancer. It took 10 years to develop. That's going to be a very easy cancer to treat. And in fact, studies have shown that if it's been more than 2 years, if the interval of time between completing therapy and finding recurrence in the liver, it's been more than 2 years, outlook is excellent, the prognosis is excellent. Those patients are going to do very well with therapy. So time from initial diagnosis to relapse is important. The number of metastatic sites in the liver is important. Again, going back to what we talked about earlier, oligometastatic disease. Small number of disease in the liver prognostically is much better than lots of areas. But there's exceptions to all rules. There's exceptions to rules. We have better treatments, and we have treated many women. I can talk to you about many women that had extensive disease throughout the liver, and with treatment, it all went away. 100% gone, 100% gone. So doesn't mean you don't try, but you have to know what you're up against. And when you see extensive disease in the liver, you have to treat much more aggressively. You don't have time to make a change in treatment or see how things go, like you do with someone who just has a couple of areas in the liver, or someone who relapsed 10, 15 years later. Someone who relapses quickly and has a lot of disease liver, they have to be treated aggressively, because if they don't, they'll get what's called visceral crisis, which means the cancer will begin to cause liver dysfunction and liver failure. Biology, again, important. We touched on that, estrogen receptor positive or negative and HER2. Constitutional symptoms. Patients who are seen and get follow-up and they get a scan, and it shows a spot in the liver and they feel fine. They're living their life, taking care of their families, doing their jobs, going to spin class. They're not symptomatic. They do very well. They do very well. They respond, they'll take treatment, the cancer will go away. Whereas the patient who has been feeling pain for 6 months, whose appetite's fallen off, who's lost 30 pounds, who's weak, debilitated, they're sort of starting out behind the 8 ball. So it's harder. So catching it early, starting treatment early is important. Outcomes are better, outlook is much better if you get a jump on it early. And then lastly, circulating tumor cells is really more of a research tool. It's not really something we use in the clinic, but if you can measure those, they correlate with prognosis. So the higher the quantity, the higher the number of circulating tumor cells, those are tumor cells in the circulating blood, the higher they are, the more extensive the problem, the more serious the outlook, the diagnosis. So those, what we just talked about, are called prognostic factors. They prognosticate the future. They prognosticate how well you're going to do and help define goals. Help to have an honest conversation about where you are, what your options are, and what your goals are. These are a little different. These are predictive features. So these are characteristics of the tumor that will help define what the best treatment is. So again, estrogen receptor. If the cancer has a receptor, it can be treated through pathways that target that receptor. And it could be as simple as a pill like tamoxifen that blocks estrogen, blocks it in circulation, but probably would be more aggressively treated today with a combination of something that blocks the estrogen receptor and something else, a drug that's called a CDK inhibitor that helps prevent resistance to the estrogen receptor blocker and enhances its effectiveness. The simplistic way to think about that is this: these are drugs that block the estrogen receptor. So they might block it in circulation, they might block the production of estrogen from the adrenal glands, particularly in postmenopausal women. And so they're sort of blocking the highway, stopping the estrogens from getting to the cancer cell, going down the freeway. But then the cancer cells learn a way to get around it. They do an end run, they learn surface streets, and they find a way to get estrogen around that block. Well, these new drugs block the surface streets, so that doesn't happen. So it helps prevent resistance and higher chances of response. I've had women with metastatic breast cancer in the liver, and that's all we did is took estrogen receptor blockers, pills, it's gone away completely, 100% gone, because they can have very dramatic responses that are durable. So again, predictive, that would predict if the patient's tumor is not estrogen receptor positive, that would predict that these kind of treatments, hormone therapies, are not going to work. HER2, only patients that have the HER2 gene will respond to HER2-directed therapy. So drugs like Herceptin and Perjeta, drugs like Tykerb, they work through that pathway. If the tumor has the pathway, that would predict they're going to work. PD-1, again, these are the new immune therapy drugs. If the cancer expresses that protein, these new immunotherapies are likely to be effective. We also look at what's called microsatellite stability. These are studies that we look at the DNA makeup of the cancer. If they're microsatellite unstable, these drugs are very likely to work. If they're not going to be effective. Women who are born with hereditary breast cancer, who have either BRCA1 and BRCA2, they're born with a genetic flaw. Their cells have lost the ability to repair damaged DNA. So there are certain drugs called PARP inhibitors. PARP inhibitors are polyadenosine ribose polymerase inhibitors that target that specific genetic flaw and make those cells behave normally again. So it reverses the genetic aberration that allows those cancer cells to grow. But again, that would only predict that those drugs are going to work with people that have that genetic abnormality, that have a BRCA1 or BRCA2 germline abnormality. And then finally, we have a new way of looking at breast cancers called next generation sequencing. What it really is genomics. And what they do, these are companies you've probably heard of. There's one that's used a lot called Foundation Medicine, and Caris is another one. But you take the tumor and it's analyzed for expression of about 100 different genes, lots of different genes. And based on that genetic expression, it may define a treatment. You may find a genetic abnormality that you didn't know was there, that a certain drug will work for. Like, oh, there's a genetic abnormality. This pill is going to work, so you can sort of marry those together. You may find something that you don't have a drug for, but there's a clinical trial. You may find a genetic flaw that you know is being tested with a new drug on a clinical trial, and having that genetic flaw will make you eligible for participation in that clinical trial. And then lastly, what you might find is a genetic abnormality where there's no treatment for it for breast cancer. But there's a treatment for it if it was lung cancer, or there's a treatment for it if it was melanoma. So it's a genetic abnormality that your breast cancer has that's been shown to be affected by a drug that's used predominantly in lung cancer. Well, you can take that drug and use it in that setting, and it's going to work. So we're in this new era of personalized medicine, individualized medicine. So we don't treat all breast cancer the same way, we don't treat all lung cancer the same way. We look at genetic abnormalities and target the individual genetic flaws within the cancer of that particular person's cancer. And they're all different. Everybody's different, all makers are different, so it's really individualized. Put this little drawing on the bottom, sort of see where does this all fall. Well, about 50% of breast cancers are going to be what we call luminal A. So those are about 50% are estrogen receptor positive or estrogen and progesterone receptor positive. And about 25% are going to be HER2 amplified. And then another 20% or so are triple negative cancers. So these are some of the targets we use to treat cancer. And again, in the liver, because the backbone, the mainstay is systemic therapy. So when targets HER2, we have antibodies and oral agents. The cyclin-dependent kinase inhibitors are these new drugs that I referred to. An example is one's called Ibrance. There's one called Kisqal. So these are drugs that work in conjunction with the estrogen receptor pathway drugs. So if you have a breast cancer and you're treating it with tamoxifen, as an example, so it's an anti-estrogen, it blocks estrogen in the circulating blood. And let's say tamoxifen stops working. The cancer starts growing, stops working. The cancer has developed resistance to tamoxifen. If all you do is add one of these drugs, if all you do, you take tamoxifen, don't change it, it's a drug that doesn't work. But if you add one of these drugs, in about 25% of cases, it will work again. Okay, so that's not good enough. We don't do that, but the data shows that it will reverse resistance and once again make the cancer cells sensitive to the estrogen therapy, estrogen blocking therapy. So it reverses resistance, but it also enhances the effectiveness if taken together. So studies show that if you take just the hormone blocker, maybe 50% chance of it working, but if you take both together, it's 80%. So it enhances the effectiveness. It extends the durability of the benefit, and it also helps prevent resistance. So a lot of women with breast cancer that's recurred, that's in the liver, that's ER positive, will get treated this way. And I mentioned a woman earlier took a pill that blocks estrogen, took another pill that's one of these cyclin-dependent kinase inhibitors, and her cancer in the liver is completely gone. mTOR is another genetic target. Similarly, these are also drugs. An example one is called Afinitor. These are drugs that don't work well by themselves for breast cancer, but when given with an estrogen blocker, they enhance the effectiveness of both drugs. And then lastly, PARP, which are the drugs that reverse the genetic flaw, targeting patients that are BRCA1 and BRCA2 predominantly. All right, so we talked about breast cancer. We talked about breast cancer that's in the liver. And we talked a lot about systemic therapy because the cornerstone of treating that is systemic therapy. But in patients that present with minimal disease in the liver, or patients who respond and what's remaining in the liver is just a small amount of cancer, local regional therapies can be very effective and can also convert them from someone who's in remission to someone who is cured. Someone who's just doing well, there's no cancer, and they could live many, many years, to someone who's cured. It's never going to be a problem again. The options are surgery, old-fashioned surgery, operate, take it out. You can take out segments of the liver. You can take out a lobe of the liver. The liver is extremely forgiving, extremely forgiving. It will regenerate. It will grow back. You can take out a lot of liver surgically, and people will grow back their liver, and they'll be fine. Imagine what we do to our livers. Very forgiving. So that's one option is surgery. Another option is what's called stereotactic body radiation, sometimes referred to as CyberKnife. So it's just a laser beam of radiation. So you may have 1 or 2 spots in your liver. You can just focus on them with a cyber beam of radiation, kind of zap them and sterilize them. Radiofrequency ablation is a process where you go in the hospital and they put you in the CAT scan machine and they give you something to knock you out like propofol, and then they can use the CAT scan to guide a needle right into the spot in the liver. That needle's got a little microwave on the tip. So it just microwaves, burns it basically, microwaves it, pull the needle back out, often go home the same day or the next day. Selective internal radiation therapy is where you deliver radiation directly into the liver. Generally it's beads, little beads that contain radiation, and you put a catheter into the artery that feeds blood. Yeah. You go through the groin here. They knock you out for it. She's going, put a catheter in and inject these radioactive beads right into the liver. So you get this intense amount of radiation in the liver and not throughout the rest of the body. And then cryotherapy, similar to radiofrequency ablation, except rather than microwaving the cancer, you're freezing it. Now, the important point, though, that these are local treatments, meaning that the benefits are limited to where you apply them. So, if you burn something in the liver, but there's cancer cells in the adjacent area, it's not going to affect those. So you have to have, to cure the cancer, you must have systemic therapy that works, and then you can use these as an adjunct to try to convert somebody from who's just getting better and going to live a lot longer to someone who's going to be cured. And sometimes we use both. I've had patients where they've had 3 spots on them, 2 of which could be very easily removed surgically. The third one's close to a blood vessel or close to another organ, some anatomy that makes it very, very difficult to remove surgically. So then what you can do is you can go to the operating room. They can do it laparoscopically. They don't have to open you up. They can do it with a scope. Take out the 2 and then take the radiofrequency ablation needle and burn the third one. Okay, so you can combine these. You have tools, you want to use the tools you have in the right order, in the right sequence to get the outcome that you want. In the 90s, the 2-year survival for metastatic disease in the liver, breast cancer, about 35% of people live 2 years. In the 90s, 35%. Today it's 75%. Wow. And if you make it 2 years, you're going to make it a lot further, because most of the women who will have problems are going to do it those first 2 years. So outlooks are much better. They're not as good as we'd like them to be. There's still a lot of research ongoing, focusing on this area. And a lot of the research is local in the liver, but all research that applies to breast cancer from a systemic standpoint will be applicable to the scenario where there's liver metastasis. So that's sort of an overview. Answer any questions if I have. Now, more often than where it does, because what you want to do is they shrink everything down, make everything better, get it to an area where it's just very manageable and local. So someone may be that way from the first time they're diagnosed. It was like one spot in the liver, it was 2 centimeters. We can do that. We can operate, we can take that out, or we can do frequent ablation right now. Or you may have someone, they got 5 spots in the liver, one of them's kind of big, it's 6 centimeters. You really can't do that, but here's what we're going to do. We're going to shrink it all down. Okay, if it's estrogen receptor positive, we'll attack it that way. If it's not, we'll attack it with biologic therapies, chemotherapy, maybe Herceptin-based. But we'll treat for about 3 months, shrink it down, get another scan. Now we've got it to a place where these are an option. But even though we do this, we're going to stay on systemic therapy for a few more months, sort of make sure there's no rogue cells anywhere that we don't want to have to survive and give us a problem in a few years. No, I would think of it the same way.
Okay.
Yeah. So it could be, you could treat the pancreas with radiofrequency ablation, right? You could treat the pancreas with surgery. Okay. It's the same surgeons, actually. Surgeons that operate on the liver, the same surgeons that operate on the pancreas. You could treat it with radiation. You could treat it with cybernetic radiation. So really, everything that we really talked about is really applicable. Okay, so I wouldn't consider that stage 4 cancer. When you have cancer and it comes back again, it often is referred to as stage 4. I would call that a nodal recurrence. Okay, it's in a node. It's technically stage 2 or maybe stage 3, but that's very different from stage 4. The reason why I make that distinction is that's a curable problem. Okay, a recurrence in the nodes can be treated, and the treatment that's going to be different with different goals than the woman who has stage 4, which is cancer in the lung and in the liver and in the brain. So nodal recurrence, I don't consider that stage 4 because what the goals are and outcomes are going to be. So that's so if you're stage 4, you're always stage 4, even when the cancer's all gone, even when you're cured. So I have patients with stage 4 breast cancer that saw a lady last week. It's been 20 years. She's stage 4, but she hasn't had any cancer in 19 years. So that doesn't change. We still call it stage 4.
Is she still taking medication?
No. No, she was very young. She's diagnosed. She's not taking medication. She's had 2 children. She's living a normal life. So if you have one spot remaining and it won't go away, first of all, it might not be cancer. It could be scar. Okay, when these cancers die, they sometimes leave a scar behind. So it could be that if you operated and took that out, you might find that it's dead cells, scar. But there might be cancer cells. But yeah, if you're down to a place where you've got one spot remaining and there's no sign of anything anywhere else, yeah, that's a situation where operating and taking it out, doing radiofrequency ablation, put a needle in it and microwaving it would be reasonable. The advantage of operating and taking it out is that you know what it is. You've taken it out, so now you've taken it to the lab and you've cut it up and analyzed it. Is it cancer, is it not cancer? When they do the radiofrequency ablation, when they put that needle in to burn it, they biopsy at the same time. So they generally know whether or not it's cancer. So if there's one spot in your liver where it looks like there's active cancer, one spot, and it can be approached. If you can put a needle in it and microwave it, I would consider that. But you also need to change your systemic therapy because this grew from 1 centimeter to 2 centimeter means it was resistant to the Braxane. So I would do both. New systemic therapy, whole body treatment for a few months. Kill any microscopic cells elsewhere, okay, because you've been taking a treatment that stopped working, but at the same time, focus on that one spot with something like radiofrequency ablation. And you've had Xeloda, you've had Abraxane, you have lots of options. There are many other drugs that you could be treated with that are going to be effective.
The clinical trial?
Clinical trial is always an option. Sure. So surveillance is really dependent on prognosis. So we went over these different characteristics that help tell you who's at risk for recurrence, who's not, who's at risk for recurrence early as opposed to later, okay? So it really depends on the characteristics of the tumor, the biology of the tumor. For instance, a triple negative cancer, if they're going to recur, they'll do it in 2 years. If you have triple-negative breast cancer and it's not there 2 years, highly unlikely you're going to face that cancer again. You're probably cured. So screening doesn't have to be that intensive because it's pretty unlikely. Whereas some of the other cancers are more likely to occur later, so they require more screening at a later time. We like to screen with physical exams intermittently. Sometimes every 2 months, every 3 months, and with time we widen the interval because the risk of a problem becomes smaller. We use blood tests, looking at liver functions, kidney functions, and tumor marker tests. There's a couple of one we follow is called the CA2729, if I'm familiar with that. So CA stands for cancer antigen. Okay, that's all it stands for. And they used to have names. So the first tumor marker we had was PSA, prostatic specific antigen. It has a name. It's for prostate cancer. Then we had another one for colon cancer called CEA, carcinoma embryonic antigen. And then we started getting so many of them that we just gave them numbers. So the one for ovarian cancer is the CA125, right? Heard of that one? And the one for breast cancer is the CA2729, or sometimes the CA153. Anyway, we use these blood tests. They're easy. They're not perfect. They're helpful, but we realize they're not perfect. So we interpret them with that understanding that they can be elevated and there's no cancer, or they can be normal and there is cancer. They're about 70% accurate. And then we do intermittent scans. And again, we have to balance the risk of radiation exposure against the benefits. So we're going to follow somebody for breast cancer for 20 years. You have to think about how often we're going to do scans and the radiation, the cumulative radiation.
Thank you so much.
Thank you.